welcome back. And as we mentioned earlier in the show, our focus for this segment is going to be looking at the Southern Regional Hospital and the quality improvement measures they put in place there. And we have a large panel, and we're so grateful that you traveled from the South to join us. We have with us Dr. Amy Hunter, who is the Medical Chief of Staff. We have Ruth McDonald, Deputy Regional Manager. We have Pearl Ellis, Regional Health Manager, and we have Angeli Olmedo, Acting Nurse Administrator. Good morning, welcome, and thank you for joining us. And I hope there's no emergency at Southern Regional this morning, because we're going to feel very guilty, right? But it's a pleasure to have you, obviously, because you cater to a very large population in the South and offer crucial services to them. So I want to start off by just finding out, in terms of your coverage, the level of service that you offer at the Southern Regional Hospital. Let's start with it.
Okay. Good morning, one and all. It's indeed a pleasure for us to be here this morning to share in terms of what we do at Southern Health Region. Let me first of all say that Southern Health Region is one of the 4 health regions in the country. And Southern Health Region comprises of the Stann Creek District and the Toledo District. We serve a population of about between 75 and 77,000. Wow. Yes, and that combined for both Stann Creek and Toledo District combined. Okay. In relation to the facilities that we have the hospitals. We have Southern Regional Hospital in Danriga. We have the Community Hospital in Punta Gorda. We have the 4 polyclinics, or what we call the primary health care, the PCPs. We have 2 in the Stann Creek District, the Danriga Polyclinic and the Independence Polyclinic. And in Toledo, we have 2 as well. We have the Punta Gorda Polyclinic and the San Antonio Polyclinic. In addition to that, we also have health centers as well. And we have a network of community health workers out in the field in the communities as well. We move on. In relation to the services, we offer both secondary care services and primary care services. In the hospital, we offer secondary. Those are care that we provide to inpatients. And we have 4 specialty areas, and those specialty areas include general surgery, pediatrics, obstetrics and gynecology, and internal medicine. And we also have as well, and in the PCPs, or in the primary health care areas, we provide primarily the primary care services, which primarily is for the outpatients. Okay, and in addition to those, we have the community-based programs, which offer services directly in the communities that aim at promoting health as well. And those areas include dental health, mental health, public health, vector control, and so forth.
Now, the primary challenge, I think if anybody were just to take a very honest and open look at the landscape, in terms of all the regional health facilities, the Southern Regional Health Facility has a very large area to be able to cover. Transportation alone, if it's an emergency case coming from Halakte, having to get to Southern Regional, there is a challenge in terms of being able to get there quickly. How do you address this issue? What has been done in terms of working with authorities within the particular areas to ensure that whatever care is necessary, that perhaps even the EMT along the way and the need for their training can be able to assist in being sure to save the life of the person who's coming from whatever far off village they're coming from?
Yes, for us, we serve and the patients, the life of the patients, that means a lot to us.
Yes.
So we are deeply committed to the people we serve. And so regardless of wherever they are, we are obligated, dedicated to serve. And so we have a referral network. And so in the communities, we have community health workers, we have rural health nurses, and in some cases we have medical officers, nurses as well. And we have, for cases that are primary care, that they can be seen and addressed there, it is done. If in cases that patients may need a higher level of care, the patient is transferred from health centers to the nearest, to the hospital, in the case of Toledo. So they may move from the health center to Punta Gorda Hospital.
We also, it's a combination of initiatives as well, because I'm based in the Toledo district, which has some of the farthest flung communities, such as Halakte.
Indeed.
Although most of the road to Halakte is now beautifully paved.
That's what I heard.
Yes. Oh yes.
So I would say that's actually one of the more easily accessible communities now by our standards. But one of the initiatives is working with the community health workers, and also many of our communities, we've encouraged them to form their own little voluntary health committees, because the fact is, even when we have ambulance service available and all of those things, that you still waste time getting there to those far villages. So we try to work with the community health workers and the village leaders to say, look, even if your village only has one vehicle, if the health committee can come up with some system within your community to say, look, if that vehicle can be available for emergencies, because that can, in a real emergency, that can save valuable time. If we do receive a call and they don't have a vehicle available, then we will do everything we can, and I would say 99% of the time, we can send a vehicle with a nurse and or a doctor to bring that patient to whichever health facility they need to receive care from. But I mean, especially in terms of pregnancy, part of what our rural health nurses and public health nurses and community health workers do is say, look, you have 9.5 months to plan for this baby. You know you live in a remote community. So when the time gets close, if you have friends or family closer to the town, go live with them for a couple of weeks. For those that don't know, specifically in Punta Gorda, we have a maternity annex facility right on the hospital compound, which has 2 bedrooms. So especially this time of year when certain communities regularly get cut off by floods, we actually say to them, look, yourself, their pregnant lady, and you can bring one person with you, your birth companion. That can be their husband, their sister, their mother, their auntie. They can stay in one of these bedrooms for up to a week before their expected delivery date. And we would provide both of them with 3 meals a day from the hospital, so that they are close by when they go into labor.
I want to say firstly a big congratulations to the Southern Regional for being on here and being vocal about some of the services that you guys provide. So a big congratulations to all of you. And we talk about achievements and quality improvement. The population rise in the South has been tremendous. We know that much. And a lot of people, especially with having better roads now to traverse from point A to point B, I'm sure that you guys get a large influx of patients. How is that dealt with in the Southern Regional? How do we deal with this?
Well, in the primary care providers, the polyclinics, they have their system set up where you have different health centers that cover certain areas. So for Dangrega, we have Pomona and Hopkins Satellite Clinic as well. They cover those communities around them. And then for independents, they have San Juan, Bella Vista, and Placencia health centers as well. And those serve those communities around them. And that way, you have a primary care provided firstly to capture any patients that might need specialist care and what's not. And we have, as Ms. Ellis explained, the referral system. The doctors from there will send on to Southern Regional if necessary, sometimes on their own, sometimes in the ambulance, depending on the case of the patient. And this ties in as well too, because we have implemented the BHIS, which is the Belize Healthcare information system, and it links everyone. So we can see what was done in Punta Gorda to their patients, what lab works was done, what testing was done, what notes they found, how the patient arrived there, the care the patient received, doctors and nurses, because everyone puts their notes in the system. So when the patient reaches to us in Southern Regional, we're not completely lost as to what happened to this patient. And we don't have to wait. And it also says when we need to do lab testing or x-rays, we know the patient has already received that in Punta Gorda. We have that as well there. Same thing applies for Independence and the Dangriga Polyclinic. Whatever notes was done, whatever labs that patient has, O labs as well, we're able to see them and we're able to address the situation in a more timely fashion in regards to those patients.
Yeah.
It makes it easier.
Yeah.
Because it's there already. It's a database that we can readily access.
Okay.
And it's
opposed to-
accessible countrywide. So
Yes.
whatever we're doing this out can be seen in Belize City, in Northern Regional, everywhere.
As opposed to having paperwork or relying on one individual, it's right there.
We're
in the
calling to try to
system.
reach the doctor.
Yes, calling and you can't get through to
Exactly.
somebody, it's right in the
Exactly.
system.
Yeah.
The whole purpose is basically to enhance the whole continuum of care,
Yeah.
so that you can see what was done in the health center, and as the patient moves along to one facility to the next, whatever treatment or care is given is documented, and so it becomes a part of the whole continuum of care.
Now let's talk about the Mother and Baby Friendly Initiative. This is very important because at one point in
Yes,
time,
it
this
is.
used to
It's
be,
very important.
I don't want to say a weakness, but the South was one of the challenging areas in terms of ensuring that mothers and babies were kept safe during delivery and postpartum. In terms of being able to, one, reach out to all persons who are pregnant or who have just delivered a baby, and also I know that there's also cultural context to be able to deal with. Some have their own form of midwifery, and some believe that they can be able to have their babies at home or in their village. And I want you to share your perspective on that, what you're seeing. Is there a change? And how do you reach out and literally reach into their homes to try to help them to have better care when it comes to pregnancy and deliveries?
Okay, in regards to baby friendly, mother baby friendly initiative, it was an initiative that was started way back in 1991. It started and then it stopped, and then, like what you said, it didn't work out. Well, in 2009, 2010, we started all over again. The thing with baby friendly is it's a mindset thing. If you're the workers, you have to change your mindset to acknowledge and incorporate everybody's differences, right? So with that in mind, it's not only about one category of people, it's everybody, right? So with the hospital, with the region, it was all healthcare workers. When we decided to take it on, because it was a lot of work, we did extensive training over and over, and it included the healthcare workers. Remember how we said in the communities we have healthcare workers, the community healthcare workers. So we had to train them. Then we trained our staff, and that included everybody from the groundsman up to the regional manager, everybody. And everybody received the same training so that we could all preach the same message and deliver the same message, right? So what we know, what the community healthcare worker knows, it's the same thing, no difference, right? When it came to cultural differences, we work, we adapt. It's not about enforcing what we believe is right. We want the patient to be able to come here at our hospital and be comfortable. So in regards to birthing positions, like the Mayas, some of them do not feel comfortable on a delivery table. They would prefer to bear down. Whatever position you assume as comfortable to you, we can adapt.
Okay.
We want them to feel comfortable. In regards to births, there are in some communities traditional birth attendants. Those are the ones that the doulas, the midwives at the community. Because some people, regardless if you tell them, you educate them, it's up to them to make a choice, right? So we can stress to them, if it's your first delivery, please come to the hospital. Please make all the arrangements. You have 9 months to plan, but sometimes it doesn't work out. But still, you have 9 months to plan. We can stress, we can reinforce. But if you choose to have a home delivery, then make sure it's by someone who is trained, right? And we advise all TBS to come to our hospital setting so that they can know what we do. right? In terms of baby friendly, there are 10 steps.
Okay.
10 steps that we must abide by. I'm not going to go through all of them because it's too long. But basically, they're so that you could foster this bond with the mom, right? Put the baby skin to skin, make sure the baby is breastfed from birth to 6 months exclusively, meaning only breast milk, no gripe water, no
sugar and water.
no sugar and water, no glucose, solely breast milk. After 6 months, then complementary, meaning breast milk plus food, right? Some people think that after 6 months, then they could stop. Stop. You still feed, still breastfeed, and still give food.
Yeah.
I'm listening to that, and it's so hard, especially in this generation, whereby folks would take heed of the fact that they should breastfeed for the entire 6 months.
It's not hard.
Some folks are actually giving their child food, water, 3 months, But one of the things people are afraid when it comes to being in a hospital is the type of attitude you will meet from somebody, from a nurse or someone of the workers in the hospital. What is the Southern Regional doing in terms of training their folks to be more people friendly?
Okay, there are a series of initiatives. The first one was a baby friendly initiative, and that's what I'm trying to get you to understand. It's all about your mindset, right? You have to understand that I need to do these things to change. If I am serving a community, then I have to be able to provide to their needs, right? So there was the baby friendly initiative that was started in 2009, 2010. Then we had the maternal and neonatal auditing. We continue to do that. We do it every month. What that does is basically, it's a series of tools that ensures that we provide the best care to the mother and the baby to ensure that they are healthy during the pregnancy, during the labor, after delivery, when the child leaves the hospital. Then there's also some OPQ tools, which they deal with improving performance.
Okay.
This is where your question falls in. Those are a series of tools, and they're very detailed to address that we recognize how we present ourselves to our clients. Specific things, like some of them ask, do you say hello? Do you say good morning? Do you identify yourself? Yes. So some things we take for granted, but when you have a guideline to ensure that it is followed, then it becomes a part of your daily routine. And it's something that it's not a one-time thing. It goes on over and over and over. We do it every year, and we do it internally and externally.
Okay.
Internally, we grade ourselves to see how we are doing, see if we are progressing, if we're detracting. But it's you go on and on.
Let me ask a question here, because one thing stands out to me in the South. When we speak about offering specific care to any region, you have to look at the nuances in that area. And one thing we know, and I know, Ruth, you can share that, especially with Toledo, with the Mayan culture, the men are very involved in the decision making.
Yes,
when we
they
talk to
are.
people who go out and do cancer screening, for example, their negotiation isn't with the woman to do the pap smear. The negotiation is to the men to allow the woman to do the pap smear. How have you worked with those? I mean, I don't know if it's different in Dangrega. I know that specifically for Toledo. But how do you work with that? Yeah.
It's the same thing, because we get their patients.
And even as a medical professional, do you find yourself doing that as well, having to kind of educate?
All the time.
In hospital care, normally the husband will come with the patient.
Yeah.
Yes.
The husband, the father, depending on the age of the patient and
Okay.
depending what type of care the patient is coming for. Or even if the mother comes, she'll say, well, I need to consult my husband. So you have to explain it to them, like, well, if that's the case, please explain it to your husband. And we try to explain to them why it's absolutely necessary for this type of care for the patient to receive. And as I said, we really do work on the husband as well too, because they're the ones that will end up saying yes or no. And when it comes to birth control, when it comes to any types of surgery, and if he's not comfortable, he'll want to consult his parents or her parents before they do make a decision. So you kind of try to impress on them the need for the urgency if it's an emergency situation, but you kind of have to give them their time to talk amongst themselves and make their decision.
Respect the fact that that's a process.
Yes.
Again,
And just to add to,
it starts from the community level again, because our community health workers, we have a mixture of men and women as community health workers. each has different advantages and disadvantages. But obviously, where the community health workers are male, then that's an advantage in that then they are more able to go to the males in the community and say, look, this is why this needs to happen. Also, we have to start it from, in terms of our activities in rural areas. If we're doing health education, we know in Toledo and in many Stand Creek villages, if you go on mobile clinic between 8 a.m. and 4 p.m. Monday to Friday, majority of the men will be out working on their farm or elsewhere. It's only going to be the women and children you see. So if there's a particular new initiative, like we have HPV vaccine coming on board very shortly, then to get the men on board, then we need to go on a Sunday, or we need to go later in the evening when they have come back from their work. So we're aware of the cultural realities that we have to work with, and that's why we count on our network of health educators, rural health nurses, public health nurses, and so on.
Exactly. And if I may add as well, we do respect the cultures of all the ethnic group, and we try to incorporate that in what we do. So if we see that in these cases whereby the men play a more active role, we would first go meet. If we need to meet with the men, we meet with them. And so that we get the buy-in from them. And once we get that buy-in from them, then we can move on with the woman.
And it's a reality
so
you face.
Yes, exactly. And we find that work, you know. So we would not go in the community without dialogue with the
And it's a long-term project, but we are seeing results. Like you were mentioning home deliveries earlier. A few years ago, we had hundreds of home deliveries every year. Last year, we had less than 50.
Oh.
So people are
So
listening.
the education process is working.
And our maternal mortality overall has stayed low. Our under 5-year mortality in Toledo has dropped by 50% in the past 3 years. So, you know, we're seeing the results.
Let me jump in, and in the interest of time, I really wanted us to touch on this one issue, which is your vaccination coverage. Belize does very well in terms of our vaccination coverage. And again, I look at the realities of the South in terms of being able to get out into the areas and be able to reach all the kids. Here in Belize, they can go to the schools, they can go to individual homes and say it's time for your vaccination. How are you guys doing there in terms of being able to keep up with vaccination coverage?
Okay, the target calls for 95% coverage, and we ensure that we work towards that. If and when we see that we're not there, we try to do catch-up clinics. And so we have mobiles in place where we do outreach, and whereby for cases that the mothers wouldn't come in, we have scheduled mobiles that we have the public health and rural health nurses go out to actually do the immunization, and we try as much to ensure that we have the necessary
especially the
in
far
place
flung
for
villages
them.
where it's a bit more difficult
We-
for them to
Yes,
get out
yes,
and come
yes.
for that
Yes,
vaccination.
that's very important
that
for
have
us.
to walk for 2 hours.
Yes, in the case
to
of
go to
a few communities in
some of our
Toledo.
communities. You know,
And it will
Take off their shoes and go through the stream.
as well as
Exactly.
it ties in with the BHIS because the
Exactly.
vaccination schedule is put in the BHIS, and so you can see. So if that patient does reach a health center, and you can check it and see, oh, they haven't received this vaccine. If it's time of the day that we can get the vaccine done, you get the vaccine done for them when they come in. And the nurses do keep a very strict schedule of who they know is missing from the vaccination. And they'll go as well to that person's house or to the community and say, well, we need these kids or we need these people to come for their vaccinations as well. And it does get done. That's how you have to work in the South. Because realistically, the distance and sometimes the financial means of the people do not allow for them to reach timely manners for their vaccinations.
All right.
And it really takes committed staff. I mean, we see these staff are so dedicated. They go to the extent to find these mothers, to find the children, so as to give the immunization. So it means a lot. It's basically protection for the children and protection as it relates for public health. So
That's right.
Vaccine targets are just one of the many areas where we're constantly monitoring. I mean, Dr. Hunter was mentioning about BHIS and how we can get a lot of information from there. And, you know, as I said, as we're seeing results. The vaccine coverage, we've kept over 95% for the past 3 years with all our key vaccines. And we've cut malaria significantly from 74 cases a year, like 4 years ago, to only 2 cases
last year.
in the entire region last year. Nurse Olmedo mentioned OPQ, Optimizing Performance and Quality Initiative, and we're seeing results. Every year we are audited,
Steadily
and Southern Regional are being assessed next week.
They did
Punta
last
Gorda were
week.
assessed last week, and we got an overall score of 92% compared to 49%
When we
5
first
years
started.
ago. And that's looking at everything from the staff we have to do the doctors and nurses follow the protocols, to do we have proper waste bins with proper covers, everything.
Well, ladies, we're so grateful that you joined us to be able to provide an update on the continuous work that takes place in your specific region. And we're grateful that we were able to share with some people. I'm sure they didn't know about some of the intricacies of your work. But you know, you offer, and as I said in the very beginning, you cater to a very large demographic in a very large geographic area.
right.
So your services are absolutely essential. So thank you for coming here and sharing with the rest of our viewers the work that you have been doing.
That's right.
Thank you for having us.
Again, congratulations, achievements and quality improvement in the southern region of Belize. But when we come back, sitcom in Belize, Living Me Life. We've got that and more in the third segment. We'll take the break. We'll be right back.